Here we're going to discuss bone, joint, and soft tissue diseases and disorders, Chapter 17. Our chapter objectives include reviewing and outlining the process of bone formation, maturation, resorption, and remodeling. Review and outline the role of mechanical stress in stimulation, bone growth, repair, and strength. Discuss diseases affecting bone, articular cartilage, and joint spaces that affect movement and function, and discuss diseases affecting soft tissue that affect movement and function. Metabolic bone diseases encompass a range of clinical disorders that affect bone structure and function due to abnormalities in bone resorption and formation. These disorders often lead to significant musculoskeletal manifestations and may require physical therapy interventions to address pain, deformity, and functional limitations. Bone composition. Bones are composed of cortical or compact bone and trabecular or spongy bone. Cortical bone is found in the shafts of long bones and makes up about 80% of skeletal mass. Trabecular bone forms a meshwork within the bone and constitutes approximately 20% of adult skeleton. The skeleton undergoes continuous remodeling throughout life, and with approximately 10% of the adult skeleton being replaced annually. This process involves the removal of bone by osteoclasts and the formation of new bone by osteoblasts. Disorders characterized by abnormal bone resorption or formation include increased bone resorption. Examples include Paget's disease of bone, osteoporosis, and bone changes secondary to cancer metastases. And reduced bone resorption. Less common disorders like osteopetrosis are characterized by reduced bone resorption and have a genetic basis. Physical therapy implications include pain management, deformity correction, mobility and function, and education and prevention. By understanding the pathophysiology and clinical manifestations of metabolic bone diseases, physical therapy can play a vital role in enhancing the quality of life and functional outcomes of individuals affected by these conditions. Osteopetrosis is an increase in bone density. Osteomalacia is softening of the bones. Osteopenia is a decrease in bone mass. And osteoporosis is a significant decrease in bone density. Disorders with increased bone resorption include osteoporosis. This is characterized by diffuse loss of bone density and strength, leading to increased risk of fractures, bone pain, postural deformity, and disability. Physical therapy's role is in primary prevention, to educate patients on lifestyle modifications to optimize bone health, including weight-bearing exercises, adequate calcium and vitamin D intake, and fall prevention strategies. Also promote healthy habits to reduce modifiable risk factors for osteoporosis, such as smoking cessation and alcohol moderation. Rehabilitation of disabled clients or patients should include the development of tailored exercise programs focused on improving bone density, strength, and balance, address postural deformities and functional limitations through manual therapy, therapeutic exercise, and functional training, and implement strategies to manage pain associated with fractures or bone pain. Osteoporosis is indeed a prevalent and complex bone disorder characterized by decreased bone mass and microstructural deterioration of bone tissue, leading to increased bone fragility and susceptibility to fractures. The pathophysiology includes bone remodeling. Osteoclasts are responsible for bone resorption, or the breakdown of old bone, while osteoblasts are responsible for bone formation, which is the building of new bone. In osteoporosis, there is an imbalance where bone resorption exceeds bone formation, resulting in weakened bone structure. Decline in osteoblast function. The decline in osteoblast function can be influenced by genetic factors, hormonal changes such as menopause, and lifestyle factors. Estrogen plays a crucial role in maintaining bone density. Postmenopausal women experience accelerated bone loss due to accelerated estrogen levels. Due to decreased estrogen levels. Bone demineralization occurs due to hormonal deficits, lack of activity, which is essential for bone health, and poor nutrition. Osteoporosis, again, is characterized by the reduced bone mass and microdamage, leading to increased fracture risk. It can be primary, which is age-related, or secondary to underlying conditions or medications. Primary osteoporosis is more common and often occurs postmenopausally in women and later in life in men. Secondary osteoporosis can be caused by medications, diseases, or other conditions affecting bone health. Risk factors include hormonal status, so declining estrogen levels in postmenopausal women specifically increase the risk of osteoporosis. Heredity and genetics. Family history of osteoporosis can predispose individuals to the condition. Certain ethnic groups have a higher risk, and lack of weight-bearing exercises can contribute to bone loss. Management includes prevention, emphasizing lifestyle modifications to optimize bone health, including weight-bearing exercises, adequate calcium and vitamin D intake, and smoking cessation. Pharmacological interventions may include biphosphonates, hormone replacement therapy for postmenopausal women, and other medications to slow bone loss and reduce fracture risk. Educate patients on fall prevention strategies and safe activities to minimize fracture risk. Common fracture sites include vertebral bodies, hips, ribs, radius, and femur, which are the most common sites for fractures in individuals with osteoporosis. Compression fractures of the vertebrae can occur spontaneously without falls. Clinical manifestation would include height loss. Osteoporosis can lead to gradual loss in height due to compression fractures of the vertebrae. Postural changes. Patients may exhibit forward head posture, increased thoracic kyphosis, decreased lumbar lordosis, posterior pelvic tilt, and knee hyperextension. Chronic back pain is a common symptom of osteoporosis, often associated with vertebral compression fractures. And again, an increased susceptibility to fractures, specifically with minimal trauma. Diagnosis is based on history and physical examination. Laboratory tests. Blood tests may assess calcium levels, vitamin D status, and markers of bone turnover. X-rays and bone mineral density tests are essential for diagnosing osteoporosis and assessing fracture management. Management includes prevention, emphasizing regular weight-bearing exercises, adequate calcium and vitamin D intake, smoking cessation, and fall prevention strategies. Ensuring sufficient calcium and vitamin D intake through diet and supplementation is important. And medications such as bisophosphonates, hormone replacement therapy, and other agents can preserve bone density and reduce fracture risks. Structural implications. Osteoporosis can lead to changes in posture and alignment affecting multiple body regions, including the spine, pelvis, and extremities. Physical therapy plays a critical role in assessing posture and designing exercise programs to improve bone health and posture, educating patients on fall prevention strategies, and implementing interventions to manage pain and improve function. Again, management of osteoporosis includes prevention and management as listed below. And PTA implications include prevention of fractures. This includes fall prevention strategies, awareness of signs and symptoms of osteoporosis, being able to identify effects of osteoporosis medications. Weight bearing and strengthening is crucial for bone health. Postural training, avoid flexion and torsion activities to minimize the risk of fractures, and safety education such as fall prevention. Osteomalacia is a progressive bone disease characterized by insufficient mineralization of new bone matrix, resulting in bone softening without the loss of existing bone matrix. The primary causes of osteomalacia include insufficient intestinal absorption of calcium and increased renal losses of phosphate. The pathogenesis includes demineralization of bone occurring due to inadequate calcium and vitamin D and/or phosphate levels. This leads to an accumulation of uncalcified bone matrix, also known as osteoid, resulting in weaker bone structure. Clinical manifestation includes generalized symptoms of osteomalacia, including aching and fatigue, anorexia and weight loss, proximal myopathy characterized by waddling gait and difficulty with transitional movements, sensory polyneuropathy, postural deformities due to weakened bone structure. Osteomalacia affects the bone matrix by causing a decrease in calcification and increase in uncalcified osteoid. Although the bone structure remains intact, the bone becomes softer and weaker due to insufficient mineralization. Osteomalacia is a metabolic bone disease characterized by inadequate bone mineralization, leading to generalized bone weakness, pain, and deformities. It is primarily caused by calcium, vitamin D, and phosphate deficiencies affecting bone matrix calcification. Paget's disease, osteitis deformis, is a metabolic bone disease characterized by abnormal bone remodeling, leading to increased bone resorption and disorganized new bone formation. Paget's disease is often inherited in an autosomal dominant pattern. Environmental factors, particularly slow viruses, may contribute to its development. The disease progresses through two phases. The resorptive phase, where abnormal osteoclast activity leads to bone resorption, with fibrous tissue replacing bone. And the sclerotic phase, where cancellous bone is replaced by thickened trabecular and cortical bone, resulting in structurally weak bones. Paget's disease progresses slowly and is often asymptomatic. Common symptoms include bone pain and skeletal deformities, hypercalcemia, fatigue, weakness, and loss of appetite, abnormal abdominal pain and constipation. Complications may arise from bone deformities, fractures, arthritis, nerve compression, or ischemia due to altered bone structure. Management involves osteoclast inhibitors to help regulate bone remodeling. Symptomatic management focuses on pain relief and addressing complications such as hypercalcemia. Paget's disease again is characterized by abnormal bone remodeling, leading to weakened and disorganized bone structure. It is primarily inherited and may be influenced by environmental factors. Clinical manifestations can vary, but commonly include bone pain, deformity, metabolic disturbances like hypercalcemia. Treatment aims to manage symptoms and prevent complications associated with altered bone structure. Fractures can be categorized into different types based on their causes and characteristics. Traumatic fractures are fractures caused by a sudden impact of force, such as falls, motor vehicle accidents, or physical trauma. Traumatic fractures are the most common type and often associated with accidents and injuries. In women, the risk of traumatic fractures increases around the age of 50 and doubles every 5 to 6 years thereafter, with a high correlation to falls. Stress or fatigue fractures are fractures caused by repetitive stress or strain on a bone, leading to microtrauma that exceeds the bone capacity to repair itself. Stress fractures are common in athletes and individuals engaging in repetitive activities that place strain on specific bones. They can result from compression or distraction forces, altering movement mechanics and increasing ground force exerted to the bone. Pain typically occurs during activity and subsides with rest. Pathologic fractures are fractures that occur in a bone weakened by a disease, condition such as cancer, or reduced bone density such as osteoporosis. Pathologic fractures can result from conditions that compromise bone strength, making bone abnormally fragile. This type of bone fracture can occur in bones affected by cancer or due to reduced mineralization, such as osteopenia or osteoporosis. Vertebral compression fractures are a common example of a pathologic fracture. Insufficiency fractures are a type of pathologic fracture occurring in bones with structural alterations due to conditions like osteopenia, osteoporosis, or disorders of calcium metabolism. Insufficiency fractures result from normal stress or forces on bones that lack sufficient elastic resistance or have weakened by mineral loss. These fractures can occur in bones subjected to regular stresses, leading to pain and limited function. Each type of fracture requires specific management and treatment approaches based on its underlying cause and characteristics. Proper diagnosis and classification are essential for guiding appropriate treatment strategies and rehabilitation protocols. Here you can see different fracture types. You have a complete fracture which is disrupted bone continuity, incomplete, not disrupted bone continuity, open with an external wound leads to fracture site, or closed where the fracture did not extend through the skin. Other fracture types here include a transverse fracture, spinal fracture, longitudinal fracture, oblique fracture, comminuted fracture, impacted fracture, green stick fracture, stress fracture, and avulsion fracture. Weight-bearing status following fractures could include full weight bearing where there's no restrictions on weight bearing. 100% of the body weight can be borne on the lower extremity. Non-weight bearing where no weight is borne on the involved limb. Foot, toes make no contact with the floor or ground. Partial weight bearing, only a portion of weight can be borne on the extremity, sometimes expressed as a percentage of body weight, such as 20% or 50%. Toe touch weight bearing or touchdown weight bearing, only the toes of the affected extremity contact the floor to improve balance, not to support body weight. And weight bearing is tolerated where weight bearing is limited by patient tolerance of weight borne on extremity. There's an example of a fracture. Clinical manifestations include point of tenderness over the site, pain at rest, pain exacerbated by movement, resistance, and/or weight bearing, edema, obvious deformity, and is often diagnosed via X-ray. Stress fractures are often hard to diagnose and don't always appear on X-ray right away. The phases of bone healing include the inflammatory phase, where a hematoma and collagen are laid out. After about a week, the hematoma is lysed by phagocytes. Pain, swelling, and warmth are often associated during the inflammatory phase. Reparative phase includes soft callus formations and begins to occur about 2 weeks. Again, remember, this is callus formation that occurs in a bone where hard bone forms. Osteoclasts remove necrotic bone, and that hard callus size eventually transitions into the original shape and size of the bone. The remodeling phase, fibrocartilage replaced by fibroosseous, remodeling in response to mechanical stresses. Fracture management often involves immobilization and surgical interventions, which are key components of fracture management, especially for displaced open fractures or vertebral fractures. Here are some details about these approaches and bone graft options. Immobilization is essential for stabilizing fractures and promoting optimal healing. This can involve casting, splinting, bracing, and depending on the type and location of the fracture. Immobilization is typically used for stable fractures that do not require surgical intervention or for temporary stabilization before surgery. Surgical interventions for displaced fractures, open reduction internal fixation, or ORIF, is often used. This is a surgical procedure to align and stabilize displaced fractures using internal fixation devices such as plates, screws, and rods. For incomplete fractures, management depends on the fracture location and weight-bearing considerations. For vertebral fractures, decompression and fusion are often used, which are surgical procedures to relieve pressure on the spinal cord and nerves and stabilize the spine with fusion of the vertebrae. Vertebroplasty is an injection of bone cement into the fractured vertebrae to stabilize and relieve pain. And kyphoplasty is similar to vertebroplasty, but involves creating space with a balloon before cement injection. Bone grafts include autografts, which are bone grafts harvested from the patient's own body, often from the iliac crest or other bone donor sites. Allografts, which are bone grafts obtained from a donor other than the patient, typically from a bone bank. The purpose of bone grafts are used to promote bone healing, fill in defects, or enhance stability in cases of non-union or delayed union fracture. The types of allografts include synthetic bone graft, which substitutes are also available, providing alternatives to autografts and allografts. Bone grafting plays a critical role in supporting bone healing and reconstruction after fractures, particularly in cases where natural healing processes may be insufficient. The choice of graft depends on factors such as location and severity of fracture, patient factors, and surgical considerations. Here are some key points related to the goals in physical therapy. Stable positioning and comfort. Providing stable positioning through immobilization techniques like casting, splinting, or bracing help to align the fractured bones and promote healing. Also ensuring comfort by minimizing pain through appropriate pain management strategies, which may include medication, elevation, and ice application. Promoting bone healing. So creating an environment conducive to bone healing through immobilization, surgical fixation, and appropriate rehabilitation protocols. Ensuring adequate nutrition and optimizing vitamin D and calcium levels to support bone remodeling and healing. Preventing complications from immobility. So addressing potential complications of immobility such as pressure ulcers, joint stiffness, and muscle atrophy through early mobilization and physical therapy interventions. And monitoring for signs of DVT or deep vein thrombosis, and instituting appropriate prophylactic measures such as early mobilization, compression stockings, or anticoagulant therapy. Stress fracture management includes initiating an initial period of rest to allow for bone healing and resolution of symptoms, with gradual return to pain-free or symptom-free activity under the guidance of healthcare professionals. Early mobilization and rehabilitation, so encouraging early mobilization to prevent complications associated with prolonged immobility, and implementing rehabilitation programs that focus on maintaining strength, range of motion, and functional mobility while respecting the healing process and any specific precautions related to the fracture type. General rehab principles of fractures. There will be the period of immobilization following a fracture. So initially, a period of immobilization is often necessary to allow for initial healing and stabilization of the fracture. The duration of mobilization depends on the type and location of fracture. Progressive stress and callus formation. After the acute phase of healing, gradual and progressive stress is applied to the fracture site to promote callus formation and remodeling of bone. Weight-bearing status typically progresses from non-weight-bearing to toe-touch weight-bearing, partial weight-bearing, and then weight-bearing is tolerated to full weight-bearing, based on fracture type and healing progress. Log rolling techniques are crucial for patients with vertebral compression fractures to minimize spinal movement and reduce pain during transfers and positioning. Low-intensity pulsed ultrasound may assist in fracture healing by stimulating bone repair and improving blood flow to the affected area. Transfer training, strength exercises, and range of motion maintenance are essential components of rehabilitation to restore functional mobility and prevent complications of immobility. Vertebral compression fractures can be challenging to manage due to significant pain and fear of movement. Pre-medication, patient education, and use of assistive devices are important strategies to promote safe mobility and independence. Studies suggest that pulse ultrasound can facilitate the repair of fresh fractures by promoting bone healing processes and enhancing blood circulation to the injured area. Complications following fractures and periods of immobilization can have serious consequences and require vigilant monitoring. Here is an overview of some common complications and their signs and symptoms. DVT, which is characterized by the formation of a blood clot in the deep venous system, commonly in the legs. Signs and symptoms include warmth, pain, swelling, redness, and tenderness in the affected extremity. Some individuals may not have obvious symptoms, and DVT can lead to more serious complications, such as a pulmonary embolism, or PE. PE occurs when a blood clot dislodges from the original site, often the legs, and travels to the lungs, causing obstruction of pulmonary blood flow. Signs and symptoms include sudden onset of chest pain, shortness of breath, rapid heart rate, coughing, which may be blood tinged, and sometimes fainting or dizziness. Compartment syndrome refers to increased pressure within a muscle compartment, typically due to swelling or bleeding following a fracture or injury. Signs and symptoms of compartment syndrome include severe pain that worsens with passive stretching of the affected muscles, pallor, numbness and tingling, decreased pulse or sensation, and tense or firm swelling in the affected area. Pneumonia and infections. Immobility can predispose individuals to respiratory complications such as pneumonia or other infections. Signs and symptoms would include fever, chills, productive cough, chest pain, difficulty breathing, and general malaise. Malunion and non-union. Malunion refers to improper healing of a fracture resulting in misaligned or shortened bone. Non-union occurs when the fracture fails to heal within the expected time frame. Signs and symptoms include persistent pain, deformity, limited range of motion, and functional impairments. Psychological complications. Prolonged immobilization and limitations in activity can lead to psychological complications such as depression, anxiety, and decline in mental status. Signs and symptoms would include changes in mood, appetite, sleep patterns, social withdrawal, and decreased interest in activities. The effects of prolonged immobilization, such as 3 weeks of complete bed rest, can indeed have significant impact on the body's functional status and overall health. Here are some key effects associated with immobilization. Decreased cardiovascular status. So prolonged bed rest leads to cardiovascular deconditioning due to decreased cardiac output, blood volume, and vascular tone. This can result in orthostatic hypotension, increased risk of blood clots, such as DVTs, and overall reduced cardiovascular fitness. Immobilization can cause joint stiffness and limited range of motion due to adhesion formation within soft tissues around the joints. Physical therapists and physical therapist assistants often work to prevent and address these issues through gentle mobilization techniques and exercise. Muscles begin to atrophy or decrease in size and strength with prolonged disuse. Loss of muscle mass and strength can significantly impact functional abilities and increase the risk of falls and injuries. Immobilization, especially in weight-bearing joints like the lower extremities, can lead to significant functional impairments. Reduced weight bearing may contribute to bone demineralization and decrease bone density. Immobility and decreased physical activity can lead to decreased bowel motility and contribute to constipation. Encouraging mobility and proper hydration are important strategies to help prevent constipation in immobilized patients. Prolonged bed rest can lead to accelerated decline in functional status and lead to effects of aging. Maintaining mobility and engagement and appropriate physical activities are essential to prevent decline. To mitigate these effects, physical therapy plays a crucial role in implementing early mobilization strategies, therapeutic exercises, and functional training to optimize recovery and patient complications associated with immobilization. Risk factors for falls include various medications, pathologic conditions, age changes, and environment. Fall prevention includes proper footwear, adequate lighting, home safety evaluation and modifications, prescriptive assistive device utilization, avoid going outdoors when it is wet, icy, or slippery, carrying items close to the body and leave one hand free to grasp railing or for balance, avoid changing positions quickly, keep needed items within reach, be mindful of pets and clutter, physical activity and exercise, avoid oversedation, and provide sturdy baseline heart rate. Here we are going to discuss various joint disorders, including osteochondrosis, osteoarthritis, and rheumatoid arthritis. Osteochondroses are a number of clinical disorders of ossification centers in the epiphyses in growing children and share the common denominator of avascular necrosis and its sequelae. These disorders are grouped together and referred to as osteochondroses with multiple synonyms, including epiphysitis, osteochondritis, aseptic necrosis, ischemic epiphyseal necrosis. Osteochondrosis affects bone growth in children and adolescents. It's caused by a disruption in blood flow to joint areas, most common in children and teenagers during periods of active bone growth. Conditions include Legg-Calvé-Perthes disease, Osgood-Schlatters disease, and Sever's disease. Symptoms often include pain, inflammation, and structural changes in bone. Treatment involves rest, physical therapy, pain management, and sometimes surgery. Early recognition and appropriate management are important to prevent long-term complications. Targeted interventions can minimize impact on bone development and function in growing individuals. Avascular necrosis, also known as osteonecrosis, refers to bone and bone marrow cell death due to loss of blood supply without infection, also known as avascular necrosis or aseptic necrosis. Osteocytic necrosis occurs due to tissue ischemia caused by impaired blood vessel function. Permanent bone tissue loss requires at least 2 hours to complete. Ischemic or anoxia. Ischemia may result from trauma, disrupting arterial supply, or thrombosis affecting microcirculation. Signs and symptoms during the initial stages may be asymptomatic despite bone ischemia. Hip pain is a common initial symptom, gradually progressing over weeks. Pain worsens during weight-bearing activities. Common tests and measures include plain x-rays, which may appear normal initially. More sensitive imaging includes bone scan, MRI, and CT scans to detect subtle bone changes. Treatment choice, whether conservative or surgical, depends on lesion size, timing of diagnosis, and presence of bony collapse. Protected weight bearing is crucial to prevent lesion collapse if surgery is not indicated. Legg-Calvé-Perthes disease is a self-limiting degeneration of the femoral head due to disturbance in blood supply. More prevalent in boys, with a 10-fold higher incidence in white individuals compared to black individuals. It is idiopathic of unknown cause with possible genetic predisposition. Trauma and anatomic disorders may contribute. The pathogenesis includes decreased blood supplies leading to delayed bone maturation. It is diagnosed with MRI, which is often used for diagnosis. Management includes containment strategies, which aim to ensure the vulnerable part of the avascular femoral epiphysis is contained in the acetabulum. Positional devices such as splints that position the hip in abduction and internal rotation. Surgery may be necessary in some cases. Clinical manifestation includes a limp with characteristic Trendelenburg gait, pain in the groin, knee, and along the thigh, muscle atrophy, and potential leg length discrepancy. Treatment goal is to limit deformity and preserve the integrity of the femoral head. Toronto hip abduction orthoses or braces help prevent femoral head deformity and restore a spherical and congruent femoral head contour within the acetabulum. The brace aims to contain the femoral head within the joint socket as much as possible. The role of joint motion. Joint motion is essential for cartilage nutrition, emphasizing the importance of maintaining some level of joint mobility during treatment. Osgood-Schlatter disease results from fibers of the patellar tendon pulling small bits of immature bone from the tibial tuberosity. It's considered a form of tendinitis rather than a degenerative disease. Osgood-Schlatter disease also can be Sinding-Larsen-Johansson syndrome, SLJ, which is similar to Osgood-Schlatter, but likely due to indirect trauma from quadriceps muscle contraction during activity or repetitive stress before complete epiphyseal fusion. The etiology is indirect trauma from sudden, powerful quadricep muscle contraction or repetitive stress. It is aggravated by bone growth in adolescence and external tibial torsion. Clinical manifestations of Osgood-Schlatter include constant aching and pain at the tibial tubercle, enlargement of the tibial tubercle with soft tissue swelling, localized heat, and tenderness. Common tests and measures. Diagnosis confirmed by radiograph or ultrasonography. Radiographs may reveal epiphyseal separation, soft tissue swelling, and bone fragmentation. These syndromes are often characterized by tendon-related pain and bone changes in the knee area, typically affecting adolescents during growth spurts. Abnormal leg alignment and posture. Knock-kneed, valgus, or flat-footed pes planus postures may increase susceptibility to Osgood-Schlatter disease. These postures create a sharper angle between the quadriceps muscle and the patellar tendon, known as the Q angle. The larger Q angle places more tension on the bone growth plate of the tibial tuberosity, increasing the risk of developing Osgood-Schlatter lesion. A high riding patella, or a patella alta, is believed to contribute to the development of Osgood-Schlatter lesion by altering the biomechanics of the knee joint. These factors highlight the role in leg alignment with patellar positioning in the development of Osgood-Schlatter syndrome, particularly in individuals with specific anatomic characteristics. Osteoarthritis, also known as degenerative joint disease, is a slow evolving articular condition that primarily affects cartilage, underlying bone, soft tissue, and synovial fluid. It is classified into primary with unknown cause and secondary with a known cause forms. Prevalence is high, affecting around 60% of men and 70% of women after the age of 65, with an estimated 40 million affected individuals in the United States. OA commonly affects weight-bearing joints like hip, knee, and knee, as well as the shoulder, spine, specifically lumbar and cervical, and certain hand joints. Etiology is multifactorial, including biomechanics, biochemistry, genetics, nutrition, weight control, estrogen use, bone density, muscle weakness, obesity, and joint laxity. Symptoms include bony enlargement, limited range of motion, crepitus, which is a grinding sensation during movement, tenderness upon palpation, and joint effusion, which is swelling, malalignment, and joint deformity. Inflammation plays a key role in symptom development, with soft tissue inflammation and edema during acute phases. Diagnosis of OA involves a comprehensive approach combining history, physical examination, x-ray, and laboratory tests to rule out other rheumatic diseases. Degenerative changes associated with osteoarthritis include joint space narrowing and articular cartilage erosion. Late degenerative changes associated with osteoarthritis include osteophyte formation and articular cartilage fissuring. Here you can see the different phases between normal osteoarthritis and advanced osteoarthritis. Clinical manifestations: unilateral presentation initially, decrease in range of motion, bony enlargement, Heberdine's nodes or osteophytes, crepitus, which is crackling or grating sensation, pain and tenderness, stiffness for a short duration, swelling, and joint malalignment. OA management includes conservative management, which includes education, weight loss, physical therapy, and orthotics. Medications include NSAIDs, analgesics, pain relievers, viscosupplementation, which is an injection of hyaluronate into the knee joint to restore joint fluid viscosity and provide pain relief. Glucocorticoids, which are steroids and anti-inflammatory properties, and glucosamine and chondroitin, which are nutritional supplements for joint health. Surgical options include arthroscopic management and reconstructive surgery, or osteotomy or joint replacements. Therapy can include manual therapy and exercise programs focusing on joint protection. PTA implications include discussing or educating your patient on weight loss, if swelling is present, the use of ice, correct biomechanical faults, so posture and footwear, possibly the use of aquatic therapy intervention, moderate exercise, resistance training and low-intensity aerobic exercises, and warm up for a few minutes to decrease reflex muscle inhibition. Etiology includes age, female gender, hepatitis B vaccine, autoimmune thyroid disease, and bacterial infections. Pathogenesis includes rheumatoid factor reacts with immunoglobulins, leading to an attack on the synovium, synovitis, which is inflammation of the synovial membrane, and destruction of collagen, cartilage, and subchondral bone. Diagnosis is often done with MRI, ultrasound, laboratory tests, including rheumatoid factor, anticytolytic citrullinated peptide antibodies, and assessment unit using an RA diagnosis criteria. Management includes NSAIDs, corticosteroids, disease-modifying anti-rheumatic drugs, and immunosuppressants and surgical interventions, including joint replacement for severe cases. Here's the criteria for rheumatoid arthritis in helping to diagnose RA. Clinical manifestations include osteopenia, osteoporosis, joint pain and stiffness for long duration, contractures, swelling, weakness and atrophy, joint deformities including an ulnar drift, which you can see in the top image, a swan neck, which is the bottom image, and a boutonniere deformity, which is the middle image. Lambert's sign, which you will see in the next slide, is upper extremity paresthesia that increases with neck flexion, subcutaneous nodules, scleritis, neuropathy, and with spine involvement, and the statement of "I hurt all over." Here you can see Lambert's sign. Symptoms and complications associated with cervical instability in individuals with RA, particularly involving C1, C2, subluxation, and atlantoaxial instability. Sensation of a head falling forward with neck flexion. This can indicate instability at the C1-2 level, where the upper cervical spine is unable to support the weight of the head properly. Loss of consciousness or syncope. Severe cervical instability can compress vital structures in the neck, affecting blood flow and potentially causing loss of consciousness. Dysphagia or difficulty swallowing can occur due to compression of the structures in the neck that are involved in swallowing process. Vertigo, seizures, and hemiplegia. These symptoms can result from neurological compression or compromise due to cervical instability affecting blood flow and nerve function. Dysarthria, impaired speech due to nerve involvement or compression. Nystagmus, involuntary eye movement, which can be a sign of neurological involvement. Peripheral paresthesia and loss of hand dexterity due to nerve compression or damage. Urinary retention or incontinence. So more severe neurologic involvement can affect bladder function. Sleep apnea due to compression at the brainstem level that leads to disturbances in breathing during sleep. The positive Lambert's sign. This is an electric shock-like sensation down the spine or into the limbs with neck flexion, indicating spinal cord irritation or compression. And vertebrobasilar insufficiency, so reduced blood flow to the brainstem due to compression or instability in the upper cervical spine, leading to symptoms like visual disturbances, loss of balance, ringing in the ears or tinnitus, and difficulty swallowing. PTA implications include educating your patient on rest during acute stages, joint protection, splints and adaptive devices, platform walkers instead of a traditional front wheel walker may be indicated. Traction is contraindicated. Do not overexert or allow for rest if fatigued. Home exercise program for strength, flexibility, and cardiovascular health. Aquatic therapy is a good intervention for these patients. Isometric exercises to reduce joint forces. Post-operative rehab if patient has surgery, and modalities for pain control. Gout. Gout is elevated uric acid levels. So gout is characterized by an elevated level of serum uric acid, which can lead to deposition of urate crystals in the joints, soft tissues, and kidneys. The causes of uric acid buildup. Purine-rich diets, so food high in purines, such as shellfish, trout, sardines, anchovies, organ meats, and beans, can contribute to increased uric acid production. Genetic factors play a role in predisposing individuals to gout. Excessive alcohol intake, particularly beer and spirits, can raise uric acid levels. Being overweight or obese is associated with higher uric acid levels. Certain medications, such as diuretics and drugs that suppress the immune system, can contribute. Medical conditions like renal insufficiency, hypertension, hyperthyroidism, and hyperparathyroidism can increase the risk of gout. Acute gouty arthritis is a sudden onset of severe joint pain, swelling, redness, and warmth, often affecting the big toe and other joints such as the knee. Chronic gout is a long-standing gout with development of tophi, which is collections of urate crystals in the soft tissues, joints, or bones, leading to chronic inflammation and joint damage. The stages of gout include asymptomatic hyperuricemia, which is elevated serum urate levels without symptoms. Acute gouty arthritis, which is sudden onset of painful arthritis due to urate crystal deposition. Intercritical gout, which is periods between acute attacks and no symptoms. And chronic trophoceous gout, persistent urate crystal deposition leading to tophi formation and chronic inflammation. Common affected joints. Gout commonly affects joints such as the knees, toes, especially the big toe, ankles, and wrists. Management and treatment includes lifestyle modifications, avoiding purine-rich foods, reducing alcohol intake, and maintaining a healthy weight and staying hydrated. Medications include NSAIDs, corticosteroids, and urate-lowering medications. Dietary changes following a balanced diet, low in purines, and high in fluids to promote uric acid excretion. And education about gout triggers, symptoms, and long-term management to prevent recurrent attacks and complications. Clinical manifestations, acute onset, so sudden and severe pain in a single joint, often occurring at night. Local signs of inflammation such as redness, warmth, tenderness over the affected joint, and the presence of tophi, which are visible as crystalline deposits around joints, indicated by the white spots that you can see in the middle image there. If poorly managed, gout can become chronic, leading to joint damage and deformity over time. It is diagnosed with lab tests, serum uric acid level measurement, which is often elevated in gout, or the triad criteria for diagnosis, which is monoarticular arthritis, so inflammation of a single joint, hyperuricemia, which is elevated uric acid levels, and prompt response to drug therapy such as NSAIDs. Connective tissue disorders that we're going to discuss are rhabdomyolysis, myofascial pain syndrome, and myofascial compartment syndrome. Rhabdomyolysis is a rapid breakdown of skeletal muscle tissue due to injury. An accumulation of muscle breakdown products can lead to acute renal failure. Physical causes include prolonged fever, electric shock, or excessive physical exertion or exercise. Mechanical causes can include crush injuries, burns, compression injuries, or compartment syndrome. Chemical causes can include medications, alcohol use, infections, and endocrine disorders. The pathophysiology includes injury and ATP depletion. Skeletal muscle tissue undergoes injury or stress, leading to ATP energy depletion within muscle cells. There's an increased fluid inside the cells. So ATP depletion causes disruption in cellular membranes, leading to an influx of fluid into the muscle cells or intracellular edema. Cellular membrane damage and lysis. Continued injury results in damage to cellular membrane components, causing muscle cell lysis or breakdown. Inflammation and myolytic cascade. Lysis of muscle cells triggers an inflammatory response and activation of myolytic cascade, leading to further breakdown of muscle tissue. Release of muscle contents. Muscle cell contents, including electrolytes, myoglobin, and other breakdown products, are released into the extracellular space and bloodstream. Rhabdomyolysis is characterized by the breakdown of skeletal muscle tissue due to various causes, resulting in the release of muscle contents into circulation. This condition can lead to serious complications, including acute kidney failure or acute renal failure, due to the accumulation of myoglobin in the kidneys. Treatment involves addressing the underlying cause, supportive measures to protect kidney function, and fluid management to prevent complications. Clinical manifestations include myalgia or muscle pain, weakness, and tea-colored urine due to the myoglobinuria, so the increase in myoglobin within the urine. Diagnosis is often done through lab tests, so there would be an elevated serum creatine kinase levels, renal function test to assess kidney function, and a urine dipstick test to detect myoglobin in urine. Management includes rehydration through intravenous fluids to maintain adequate hydration and prevent kidney injury, correction of electrolyte imbalance by monitoring and correcting the electrolyte levels, examples potassium and calcium, dialysis if severe kidney injury or acute renal failure develops. Dialysis may be necessary to support kidney function and remove toxins. Monitoring for complications, arrhythmias due to electrolyte imbalances, and close monitoring of renal function and urine output. Disc conditions include herniated nucleus pulposus, degenerative disc disease, and internal disc disruption. Herniated nucleus pulposus is a change in the shape of the intervertebral disc annulus, causing it to bulge beyond its normal perimeter. It is the most common disc disease of the middle-aged population. Location and characteristics in the cervical spine. Central posterior bulge often occurs. In the lumbar spine, a posterior lateral bulge. In L5, S1, an anterior bulge, which is less common. The etiology is overstretching and or tearing of the annular ring, vertebral end plate and or ligamentous structures due to high compressive forces or repetitive trauma or injury. It is diagnosed through an MRI, which is the preferred diagnostic tool. Management includes pain management with acetaminophen, non-steroidal anti-inflammatory drugs, muscle relaxants, trigger point injections, and corticosteroids for inflammation and pain. Disc bulge refers to the condition where there is an alteration in the shape of the intervertebral disc, often due to mechanical stresses or injury. It commonly affects the cervical and lumbar spine and can cause symptoms like pain, stiffness, and limited mobility. Diagnosis is typically made through MRI imaging, and management focuses on pain relief and addressing inflammation and targeted injections. Categories include disc protrusion, where the annulus bulges but is intact; extruded disc, where the nucleus extends to annulus but nuclear material is intact; and sequestrated disc, where the nucleus is free beyond the canal. Clinical manifestations include decreased strength, radicular pain, which is pain that radiates along the nerve path; paresthesia, abnormal sensations like tingling or numbness; and decreased ability to perform activities of daily living or ADLs. PTA implications include positional gapping for 10 minutes, using specific positioning techniques to create space between vertebrae and relieve pressure on the affected disc; dynamic stability exercises, such as implementing exercises that target core stability and improve control of spinal movements to support the affected area; and patient education on body mechanics, so teaching proper body mechanics and movement techniques to reduce strain on the spine during daily activities; manual techniques such as traction, applying traction forces to the spine manually or using mechanical devices to alleviate pressure on the disc and relieve symptoms; and symptom centralization, which is monitoring and assessing how symptoms change and potentially centralize to improve with specific interventions guiding treatment adjustments. Degenerative disc disease is a loss of ability to absorb water and dries out over time. There's a decrease in water content, which decreases disc volume. Bone-on-bone contact will eventually occur, osteophyte formation, and lateral stenosis. So age-related changes leading to a decreased water content in the intervertebral disc leads to a loss in disc volume, resulting in bone-on-bone contact, formation of osteophytes or bone spurs, and lateral stenosis or narrowing of the spinal canal. Clinical manifestations include radiculopathy, pain, numbness, tingling, or weakness along the path of the nerve root, often due to compression or irritation; stiffness in the affected area of the spine; distal weakness of the muscles further away from the spine, often due to nerve compression; decreased deep tendon reflexes due to nerve involvement; numbness and tingling sensations in areas supplied by affected nerves. Management includes NSAIDs, weight loss to reduce mechanical stresses on the spine, steroid injections into the epidural space around the spinal cord to reduce inflammation and pain, and surgery options such as a laminectomy, so removal of part of the vertebral bone; fusion, which is joining the vertebral bones together; discectomy, removal of the part or all of the disc; or artificial disc replacement. PTA implications include range of motion and flexibility exercises, postural mechanics training, strengthening, and modalities for pain control. Spinal stenosis, degenerative arthritic changes in the spine, such as osteoarthritis, leading to bone and tissue changes that contribute to narrowing of the spinal canal. The pathophysiology includes progressive narrowing of the spinal canal due to degenerative changes, which result in compression of nerve roots or the spinal cord. Compression of neural structures leads to vascular and neural compromise, resulting in symptoms. Clinical manifestations include position-related pain, pain that worsens with certain positions or activities, particularly extension of the spine, and usually improves with flexion; numbness and tingling sensations, such as pins and needles due to nerve compression. Diagnosis is done through MRI or CT scan, X-ray, and myelography, which is radiographic study involving contrast dye injected into the spinal canal to visualize spinal structures. Management includes acetaminophen or NSAIDs, corticosteroids, muscle relaxants, trigger point injections, and surgical decompression. PTA implications include dynamic trunk and pelvic stabilization with flexion bias activities, avoiding extension in positions that narrow the canal, ipsilateral side bending and rotation, and traction. Spondylolisthesis and spondylosis. Spondylosis is a broad term used to describe general degeneration in the spine. Spondylolysis is a defect or a fracture of the pars intra-articular with a positive Scotty dog sign. Spondylolisthesis is an anterior slippage of one vertebrae over another after a pars fracture. It is the most common in L4 and L5 or L5 and S1. So spondylosis definition is a general term used to describe the degenerative changes in the spine, including disc degeneration, osteophyte formation, and facet joint arthritis. Clinical manifestations can include neck or back pain, stiffness, and reduced range of motion. Spondylolysis is a defect or fracture of the pars intra-articularis, which is a small bony segment connecting the facet joints in the spine. Clinical manifestations would include pain, particularly with activities that involved hyperextension, of the spine. Diagnosis would be the Scotty dog sign on imaging studies such as X-ray or CT, where the appearance resembles a dog, which you will see on the next slide. Spondylolisthesis is an anterior slippage of one vertebrae over another, often occurring as a result of spondylolysis. The most common locations are that L4, L5, and L5 S1 levels. The etiology, it can be congenital or present at birth or acquired due to spondylolysis. Clinical manifestations include back pain, radiculopathy, and potential neurological deficits if severe. It is also diagnosed with X-ray, CT scan, or MRI to assess the degree of slippage. Management includes acetaminophen and NSAIDs, corticosteroids, muscle relaxants, trigger point injections, conservative treatments such as physical therapy to improve strength, flexibility, and posture. Surgical management involves decompression and fusion surgeries, which are procedures aimed at relieving nerve compression and stabilizing the spine by fusing affected vertebrae together. Here you can see the spondylolysis, which is that Scotty dog sign, and then the spondylolisthesis would then be that anterior slippage, which is occurring. If you look at the right image, you can see that one vertebrae has slipped forward beyond the neutral position. For spondylolysis and spondylolisthesis, the management approach focuses on dynamic stabilization of the trunk, particularly strengthening the abdominals and multifidus muscles. Patients should avoid positions that add stress to the defect, such as extension, ipsilateral bending, or contralateral rotation. Patient education is crucial to emphasize proper posture and limitations in activities that could exacerbate symptoms and worsen the condition. Additionally, spinal manipulation is generally contraindicated in these cases due to the risk of aggravating the pars defect or causing further vertebral slippage. Spondyloarthropathies. That is a tough word to say. Formerly considered variants of rheumatoid arthritis, They are now recognized as distinct entities with similar features affecting the spine. There are various types, including ankylosing spondylitis, psoriatic arthritis, reactive arthritis, including those associated with inflammatory bowel disease, and Reiter's syndrome. It's characterized by inflammation of spine joints. Inflammatory eye disease occurs in about 25% of individuals. Arthritic symptoms can flare with inflammatory bowel disease and typically affect the lower extremities asymmetrically. Vasculitis, clubbing of the fingers, and skin changes may be present in some cases. Ankylosing spondylitis, also known as axial spondyloarthritis, is an inflammatory disease that can lead to fusion of vertebrae in the spine over time. Sjögren's syndrome is an autoimmune disorder characterized by dry eyes and dry mouth due to immune system attacking healthy cells that produce saliva and tears. Often occurs alongside other autoimmune conditions like rheumatoid arthritis and lupus. Treatment includes eye drops, medications to manage symptoms, and in severe cases, eye surgery. Ankylosing spondylitis is a progressive inflammatory disease of unknown etiology that primarily affects the axial skeleton, with onset typically between ages of 15 and 30. Men are affected 3 times more often than women, and it's more prevalent in Caucasians. Etiology is influenced by gender, race, age, and family history. The pathophysiology includes chronic inflammation at the attachment sites of connective tissues that leads to ossification and bamboo spine formation. AS, ankylosing spondylitis, primarily affects the sacroiliac joints, apophyseal or facet joints, costovertebral joints, and intervertebral disc articulations. The exact cause of AS is not fully understood, but chronic inflammation at ligamentous bone junctions is a key feature. Reactive bone formation occurs as part of the repair process, leading to progressive ossification and bony growth between the vertebrae. Clinical presentation and diagnosis. Common symptoms include new onset of back pain, sacroiliac or hip pain without trauma or overuse, accompanied by systemic signs like fever, fatigue, or respiratory compromise. Diagnosis is based on radiography and laboratory tests. Management includes treatment including NSAIDs, corticosteroids, cytotoxic drugs, and tumor necrosis factor inhibitors. Physical therapy plays a crucial role in managing AS by maintaining flexibility, strength, and function. Disease progression can lead to a fused rigid spine, also known as bamboo spine, in advanced stages. Clinical manifestations of ankylosing spondylitis include insidious onset of mid and low back pain, which can be described as a dull ache with intermittent sharp pain. Cough, sneezing, and rotating increase the pain. Radiates to the thigh but not lower. Stiffness lasting 3 months or longer. Sacroiliitis, which is sacroiliac joint inflammation, and kyphotic deformity and decreased lumbar lordosis. PTA implications include aerobic capacity. Do not over-exercise these patients. Aquatics may be a good alternative. Reduce inflammation. Flexibility exercises with an extension bias. Postural control. Strength training. Breathing strategies to maintain or improve vital capacity. Maintain respiratory functions. An exercise program of 50 minutes 3 times a week. No high impact and no flexion exercises.